Sounds good. So welcome to our first RFS Journal Club webinar series. This year, we're doing something new by creating a standalone RFS Journal Club series, integrating the meetings from each individual service line. So in the past, individual service lines have held separate meetings, but it's been difficult to invite members from outside of the respective service lines to participate. And as our scholars, we're interested in every topic, not just the ones that pertain to our service line. So but our hope is to now be able to record broadcast presentations to all of RFS. So as such, we're inviting all service lines to participate and contribute with their own journal club meetings. The first series, as for the one you see here, for instance, will be presented by the Vascular Disease Service Line. But if you have any topics already scheduled to present it in your own that you would like to present in the future, go ahead and email us. So the coordinators are me, Justin, and then Rashid, who is a medical student from the University of Illinois, Chicago. Our email addresses are written here. If you guys us, and then you will be added to the presentation schedule. Also, throughout the year, keep an eye out because the communication communications group will also be sending out invitations through email. If you guys have any topics, then go ahead and reply with your topics. All right. So the first session of our series today will be presented by the Vascular Disease Service Line, like I said, under the direction of the co-chairs Akil Kartapal and Matil Pandi, as well as our mentor, Dr. George Vatakencherry. The presenters will be VDSL members, Almer and me. We'll be presenting topics on the 15-year EVAR data, as well as treatment of varicose veins. And our faculty moderator will be Dr. Vatakencherry. Dr. Vatakencherry is the director of the Diagnostics Radiology Residency Program at Kaiser in Southern California. He's the assistant clinical professor of radiology at USLA as well, the founder of SIR Resident Fellow and Student Section. He went through medical school at the University of Florida, did residency at the University of Chicago, and completed his fellowship in cardiovascular and interventional radiology at UCLA. So our first presentation will be Amer. I will go ahead and give Amer the screen here.
Hi, can everyone hear me?
I can hear you.
Yep, I can hear you, Amer.
Great.
Yeah, go ahead.
All right, so what I wanted to present today is the EVAR 15-year data, and like I said, or like Justin said, I'm Amer Rashid, third-year medical student at the University of Illinois, actually at the Rockford campus. So here we go. So the importance of this trial is that here I can hide the control panel. There we go. Okay, so the importance of this trial is that you know, there's been multiple trials that I've looked at endovascular versus open repair for abdominal aortic aneurysms, and some of them are shown over here: the DREAM, the EVAR, and the OVER trials. These are really the big three trials, and they showed a significant improvement in terms of mortality when looking at the first 30 days with the use of endovascular aneurysm repair. However, all three of these studies later published data which revealed that the mortality benefit was lost after a number of years. And the EVAR 10-year data actually showed no difference between aneurysm-related mortality, or showed no difference between endovascular repair and open repair when looking at aneurysm-related mortality and total mortality at 10 years. And they also began seeing the problem of secondary sac rupture with endovascular repair. So given these concerns, the EVAR trial was extended and now we're looking at the EVAR 15-year data. So who was participating in this trial? Men and women greater than 60 years or older. They enrolled patients between September 1999 and August 2004. They were looking at they conducted this trial at 37 hospitals in the UK. Some of their inclusion criteria included aortic aneurysms 5.5 centimeters in diameter, and they looked at this via CT. And they and they another one of the inclusion criteria was that the aortic morphology had to be compatible with the endograft placement, and also on the flip side, they needed to be deemed fit for open repair, and this was decided by a surgeon, radiologist, anesthesiologist, and cardiologist. So how did they do the follow-up? They wanted to follow up annually with clinical symptoms and imaging as well, and also measure serum creatinine concentrations. And the management of the aneurysm-related complications was left to the discretion of the trial centers. Outcomes. So what were they looking at? Primarily aneurysm-related mortality and total mortality, and the secondary outcomes that they were looking at were reinterventions. How did they do the statistics? Well, by 2009, they still had 711 patients under follow-up. This gave them 80% power at a 5% significance level to detect a hazard ratio of 1.25 during this extended period, assuming that 10% of the patients were still alive by the end of the period. And the analyses were done on the based on the intention to treat. So essentially, if somebody was assigned to the EVAR endovascular repair group, but they actually ended up getting open repair, they would still be looked at under the endovascular repair group, and the same with open repair. So if somebody was assigned to the open repair group, but they ended up getting EVAR, they would be still analyzed under the open repair group. And then something interesting that they did was just considering the stratification of the data, they also looked at the data by splitting it up by time intervals. So from randomization to 6 months, 6 months to 4 years, 4 years to 8 years, and then 8 years onward. And we'll see how important this is when we look at the results. Okay. So the results. So the first thing is the baseline characteristics, and the bottom line is that when comparing both of the groups, the open repair group and the endovascular repair group, there was no significant differences. You can see the variety of criteria that they looked at: age and smoking status and blood pressure as well, ABIs. And I've linked this paper as well as the other papers as well. So if anybody like to look more at the data and look at the indices and like, they can do that by viewing my references section. And then in terms of the patients, so they initially enrolled about 1,252 patients. They had an equal number assigned to both groups over here. Initially, they had lost a few patients to follow-up, so we can see 9 patients in the EVAR group and 8 patients in the open repair group. But actually, they used a little bit of a different methodology when getting the 15-year data, and by using this other method for data, they were actually able to recapture some of the lost patients, as we see over here. And at the end, 626 were included in each group for the intent to treat analysis, and 598 in the per protocol analysis for the EVAR group, and 567 in the per protocol analysis for the open repair group. So the follow-up duration was very significant. So mean almost 13 years and median at 12.4 years, and the mean person years to death / the end of the study was 8. And as we'd expect, the annual follow-up with CT or duplex imaging decreased over time, and as we'd also expect, the CT scans in the EVAR group are greater than the open repair group, but it's interesting what the numbers were. And we can see that it's double over here. The open repair group had 3 CT scans over their follow-up versus 6 CT scans for the EVAR group. Okay, so primary outcomes, what did they find? Well, when looking at total mortality, over the whole time interval, we see that there was no significant difference between both the groups, the endovascular repair group and the open repair group when looking at total mortality. So no significant difference over there. And then also no significant difference when looking at aneurysm-related mortality over the entire time interval between the two groups either. But what's interesting is that after the 8-year time interval, we see that there is a significant difference for both total mortality as well as aneurysm-related mortality for both groups. You can see the data right over here. And it's important to note no significant interactions between treatment groups, age, sex, or hello, can you guys hear me now? I think my microphone was muted for a second. Okay, so, and again, there was no significant interaction when looking at the data between treatment, between age, sex, aneurysm diameter for either the aneurysm-related mortality or total mortality. And I think it's also important to look at the per protocol analysis. So again, per protocol is if somebody was in the open repair group and they ended up actually getting EVAR, then they would be analyzed under the EVAR group when looking at the per protocol analysis. And when we looked at this per protocol analysis, overall aneurysm-related mortality was significantly higher in the EVAR group, as we can see over here, but total mortality was not significantly different between the two groups. Okay, so cause of deaths is also very important to look at. In the EVAR group, total deaths were 466, and the open repair group 444. Rupture after aneurysm repair resulting in death. In the EVAR group, this was 31. In the open repair group, 5. And then this statistic is especially where I found this very interesting. So overall, cancer-related deaths between the two groups, so EVAR and the open repair, were not significantly different. But after the 8-year time interval, there was a significant difference between these two groups. And I think Dr. V will comment on this later, but they actually don't discuss this too much in the discussion section of the paper. But they do mention that this should be something that's that we should look further into. Okay, so now secondary outcomes. So this looked at any reintervention, any serious reintervention, and life-threatening reinterventions. And we can see that over the whole time interval, there was a significant difference favoring the open repair group for all 3 of these secondary outcomes. And this was actually most significant, or the relative difference between the reinterventions was greater at the 6-month to 4-year time interval. So right over here for all 3 of these. And I thought what was interesting was even after 2 years or 5 years of follow-up without any life-threatening reintervention, new life-threatening reinterventions occurred at any time up to 15 years of follow-up. So what does this mean? Like we mentioned before, we have the results over here. And the last point that I mentioned, so even after the 2 years or the 5-year follow-up without any life-threatening reintervention, new life-threatening reinterventions occurred at any time up to the 15-year follow-up. I think it's important to say that the study suggests that it's not safe to stop follow-up in patients after EVAR at any time interval, really. And then also talking about aneurysm-related deaths, secondary sac rupture was more common in the EVAR group and could occur at any point after the procedure. Secondary sac rupture is rare after the open repair and tends to occur during late follow-up. Rate of reintervention was also higher in the EVAR group at all time intervals. This is also important to point out that after the first 6 months, increase in aneurysm-related deaths in the EVAR group was largely due to secondary sac rupture over here. But the 31 deaths from secondary sac rupture were partly due to not having underlying causes of sac expansion from endoleak corrected. So looking at this, maybe this is something that we could address that could significantly change the results. And I mentioned this on the next slide, looking at some of the things that we could look at in the future. So, but before that, we'll mention some of the limitations of the study. And one limitation is definitely that EVAR today uses newer devices which may yield better results. Imaging has also improved to establish size and placement of endografts. And the original trial actually wanted follow-up via CT scans, but they later, a lot of people started following up with ultrasonography as this was less radiation, so maybe this had an effect on the trial as well. And patients in the EVAR group were more thoroughly followed, which may have caused an underestimation of aneurysm-related mortality in the open repair group, but this still didn't really affect the total mortality findings. So what does this mean, and where should we head in the future? So like I mentioned over here, we need to develop guidelines for surveillance of EVAR that are easy, regular, and avoid CT scans if possible, or limit radiation to patients. And we also need to concentrate on monitoring sac diameter by ultrasonography or new methods, because like I mentioned, 2 aneurysm-related deaths followed reintervention, but 31 deaths from secondary sac rupture were due to not having underlying causes of sac expansion from endoleak corrected. So if we can monitor the sac expansion and detect it and fix it, maybe we can prevent some of these deaths. And here are my references for the study. Are there any questions from the audience? Feel free to just unmute yourself and ask, or you can also post in the questions box as well. If not, Dr. V, do you have any comments that you'd like to share about the study? Okay, if not, then I think we can move on to Justin's presentation. Justin, you can go ahead and retake control.
Yeah, so I'm sorry. I think that the data is rather impressive, that you have 15-year data on a prospective interventional trial, and it tells you how important longitudinal follow-up of any implant that you put in as an interventional physician is. And I think the implanting physician is ultimately responsible to take care of these patients, as is evidenced by filters. And so if you don't have a way of following these patients, you probably shouldn't be doing these implants.
Definitely, just follow up. Just emphasizing the importance of follow up. I think it's really important.
Yeah, I think that's showcased now with filters and the complications we've seen with that. And so if you put a filter in and you don't follow that patient, it's also kind of a potentially detrimental, as we're seeing the fractures, migration, thrombosis, et cetera. And obviously with endovascular aneurysm repairs, any of these things that we put in implants, I think they will need some type of longitudinal follow-up.
And Dr. V, they mention over here that EVAR today uses new devices. How significant do you think that this impact is, the new devices? Do you think that they're really that much better than the devices that were used in 1999 to 2004?
I definitely think there have been some issues that have been addressed, like some of the limb thromboses have been addressed with better limbs, with more support. I think that some of the neck morphologies have been better addressed with maybe different material and different fundamental factors as far as flexibility of the grafts. The permeability of the material has also been addressed in some of the grafts that had some endotension, et cetera. So I do think that the companies have learned from the issues that have been at hand and have addressed them with newer technology. Now, there is a push and move towards less and less more smaller profiles, meaning 12 French or 10 French or God knows what. But do we have the technology, meaning the structure from the fabric and the metal, that will not undergo fatigue in order for that to be able to be done? Right. It's too early to tell. So you got to be careful, because as we move towards smaller, it may mean smaller profile, but it may not mean as durable or robust. So there is some kind of challenges that we're going to face as we keep on pushing the envelope.
Agreed. And then, do you know of any new novel methods that they're looking at right now to detect the expansion of the sac?
So, I mean, the expansion of the sac, really, cross-sectional imaging is probably the best. And then, as far as other methods, they've had this thing called the CardioMEMS, which is an intra-sac pressure gauge. It never really got to where they basically, you could put an RFID and you could see if the sac is increased or not. This is help developed by Jay Ottav. However, it never really took off, but some people would implant them into the sac and use that as a surrogate. But no, not really. We haven't really identified those who are going to grow or not in a great fashion. We can use MR, we can use CAT scan, we can potentially use ultrasound as well.
Well, thank you, Dr. V. Do you have any other additional comments? Or?
No, that's pretty much it. Any questions from the audience about this? Dave, Brett, anyone who may be on the call? Yeah, Dave?
I think the attendees are all muted right now.
All right, can we open them up?
Yeah, hey guys, can you hear me?
Yeah.
Thank you. Yeah, thanks for the great overview of that article. Definitely very powerful article or trial. A quick question, I may have missed it, but just wondering as far as follow-up, how many of these patients were ultimately lost to follow-up? I know, like talking back to the IVC filters as an analogy, that's often a difficult thing, is to get these patients back. I know this is kind of a different subset of patients that are probably followed more closely in general, but just curious as far as the numbers on that, and also Dr. V, if you have any personal experience on how to try and bring these patients back more regularly, because on personal experience this has been difficult.
Yeah, I mean, as I bring them back on a routine basis from, I don't know, maybe Amr, you can pull up the slide on the loss to follow-up, but in general, overwhelmingly, surprisingly, I have a pretty decent follow-up for the most part on these patients, getting the scans done and following them up in the office. I think when it comes to, even for filters, I've been able to get more and more patients as I tell them the potential risk, and they're aware of it, they're more cognizant of it, and they know what I'm looking for, they're more likely to come back and go, hey, is everything okay? So I think if you educate the patients about what's going on and really spend some time with them in the initial consultation as well as in follow-up and tell them why it's important and show them some cases of why that's important, I think they'll be less reticent to not show up in your office, you know? And so I think if they know there's a potential ticking time bomb when it comes to an aneurysm that can still potentially rupture if you don't have good follow-up, they're going to come in. I think if you tell them there's a filter that can fracture or migrate to various places, I think they're more or cause clot formation, they're more likely to show up, you know. But if oftentimes patients aren't told about the relevance of it by their implanting physician or by the service, and I think it's imperative that we do a better job as interventional physicians telling them this is what's going on, booking them in your clinic and developing a longitudinal relationship with the patient. So if I tell a patient I meet them every year, they appreciate it. And I think that's what's been lacking, is their face time with the patients in a longitudinal fashion as a physician, interventional physician.
Absolutely. Thanks, Dr. V.
David, were you able to see the screen with the...
I was, thank you. Yeah, I saw that chart. Thank you.
Yeah, no problem.
Great. Yeah, it sounds like just fostering that relationship in the clinic setting, building that relationship like you have, Dr. V, really will be beneficial.
I think so.
All right. Any other questions?
All right.
Yeah. Okay. If not,
right,
then...
If not, I guess we can move on, yeah.
Yep.
So can everyone see my screen here?
No, we can't. I can't see it yet.
Let me try again. How about now?
Yep, can see it now.
Yep, we can see it now,
Okay,
Justin.
Great. So, so again, good afternoon. My name is Justin, one of the first-year PGY2 radiology residents from the University of Iowa. Today I'll be presenting the article on a randomized trial comparing treatments for varicose veins. So whereas Amr presented a paper on arterial and aortic disease, so this is more concentrated on venous disease. So as a quick introduction, ultrasound-guided foam sclerotherapy and endovenous laser ablation are common alternatives to surgery for treatment of varicose veins. Prior randomized controlled trials and meta-analyses have shown the short-term technical success and clinician-reported outcomes of these alternative therapies to be very effective. However, the clinical practice guidelines recommend using patient-reported quality of life to assess outcomes of varicose veins treatments. So there have been two small randomized controlled trials in the past comparing surgery and endovenous laser using quality of life as a primary outcome measure. However, quality of life has not been assessed as a primary outcome in randomized controls involving foam sclerotherapy. So that was the purpose of this paper written by these authors here. So the authors had performed a comparison of laser, surgery, and foam sclerotherapy trial, and they used the data from that trial, which was based in the UK. It was a large multi-center randomized comparative effectiveness trial to assess quality of life and other outcomes for varicose veins treatments. And so they did a quality of life outcome evaluation for this paper, while they also published a trial looking at the effectiveness of treatments in terms of the costs to the patients and healthcare in general. So this is basically comparing the three treatments, sclerotherapy, laser therapy, and surgery. So the way they recruit the patients, they had all patients requiring treatments for varicose veins from 11 vascular surgery departments register between November 2008 and October 2012. All patients were assessed by their vascular surgeons, as well as duplex ultrasonography, to see whether the patients are suitable for treatment and entry into the study. The inclusion criteria included age, whether the patients were more than 18 years old, primary symptomatic varicose veins. So they used this clinical, etiologic, anatomic, and pathophysiologic classification, whether the patients are grade C2 or higher. And grade C2 basically meant that the varicose veins were greater than 3 millimeters in diameter. They also looked at for patients who had reflux of the saphenous veins of greater than 1 second on ultrasound. Patients were excluded. They had concurrent DVT or acute superficial venous thrombosis. So they also make sure that the patients met this criteria between 3 and 15 millimeters of diameter in the veins. The veins were not suitable for laser treatments, or there was contraindications for foam or using anesthesia, then the patients were excluded as well. The patients were randomized using a computer-generated system. They were stratified according to the center, because not all 11 centers offered all three treatments. So 8 of the hospitals, the patients were put into stratum A because they offered all three treatment options, but then 3 hospitals only offered foam and surgery, so they were put into stratum B. They tried to randomize the patients to achieve equal assignments to all the treatment options available. They used the minimization algorithm to make sure that they had an equal number of patients randomized in regards to center where the treatment was performed, the patient's age, their gender, and then the reflux of the veins, and then whether or not there were unilateral or bilateral varicose veins. So the treatment methods are what you see here. There's proximal ligation, phlebotomies. There's also foam sclerotherapy, and then there was laser ablation. So for these treatments, if the patient had any residual varicosities at 6-week follow-up, then they could have undergone further foam sclerotherapy, and all treatments were done under local anesthesia. And then the patient, so the paper also made a point that the study had very good oversight. there was a research ethics committee, and then there were the Healthcare Products Regulatory Authority that oversaw the study. All patients had written informed consents. There was a steering committee that looked at the data and safety monitoring issues independently. There was, and then the data analysis was performed by statisticians at the University of Aberdeen, where the study was performed. There was also a project management group to make sure that the data accuracy, the data completeness, how the data was presented, were all had fidelity to the study protocol. And then the outcomes were assessed at baseline and then at 6 weeks and 6 months after treatment. So in terms of the statistical analysis, the patients were, so they did an intention to treat analysis, compare the treatment options. So they first compared foam and surgery using stratas A and B, and then they did laser and surgery comparison using strata A. And then they did this post hoc analysis that compared laser and foam. And then the principal analysis was performed after the study was over at 6 months. And then they used general linear models to analyze comparisons between the groups. They used the mixed model analysis system to look at repeated measures, and they analyzed continuous outcomes from that. And then the saphenous vein ablation rates were analyzed with ordinal logistics regression, complication rates with binary logistics regression, and a sensitivity analysis when there were missing data reported at 6 months. So here are the results. They basically had 6,592 patients that were registered, that were eligible. They ended up taking out 2,847 patients because they didn't meet the inclusion-exclusion criteria. 376 were not included because of, well, they had unknown eligibility status. So in the end, only 3,369 were eligible for the study. 2,571 patients declined to participate. They said that the main reason for that was because they wanted a specific treatment that they were not randomized to. 798 then underwent randomization. As you can see here, 292 underwent foam, 294 underwent surgery, and 212 underwent laser ablation. So here's a table that had the baseline characteristics of the patients. The characteristics were generally similar among the groups, except for there were a few exceptions here. The diameter of the saphenous vein was a little bit larger in the laser group compared to foam, with a p-value of 0.008. There was incidence of reflux below the knee that was greater in foam group than in the laser group. The incidence of prior DVT was less in the surgery group than in the foam group. And then patients who were randomly assigned to treat with foam or laser. So I kind of mentioned this, but the patients, who were assigned to foam or laser also had the option of treating with foam for any residual varicosities at 6 weeks. So 38% of the patients from foam and 31% of the patients from the laser group underwent further foam sclerotherapy. As you can see here, these were the outcomes in terms of how many percentage of patients had completed their clinical assessments and completed their questionnaire. So sorry, I just want to go over this real quick because I think I skipped this slide earlier. So the primary outcome measure they were looking at was basically looking at the quality of life of the patients, and this was a patient reported at 6 months. So they used this disease-specific quality of life measurement called the Aberdeen Varicose Vein Questionnaire, the AVVQ. There was a generalized quality of life called the Euro QOL Group 5 Dimension Self-Report Questionnaire, EQ5D, and the Short-Term Health Survey. They also looked at secondary outcome measures at 6 weeks and 6 months, looking at the clinical success, basically proportion of patients with residual varicose veins, and also the venous clinical severity score, and also the complications. And this clinical success was measured by both the patients and the healthcare provider, the surgeons and nurses. And then they also combined the results from the questionnaires above and looked at the ablation rates of the main saphenous veins. All right, so in terms of the primary outcome at 6 months, the AVVQ score they found that was higher in the foam group, which means that the disease-specific quality of life was worse in the foam group compared to surgery. The score was similar in both the laser group and the surgery group. The EQ-5D and SF-36 physical score, which were measures of general quality of life, had really no significant differences between the groups. The post hoc analysis of laser versus foam found only a significant difference in the SF-36 mental score, which was basically a measurement of mental well-being, and the p-value is 0.048. The AVVQ score was significantly worse in the foam group than in the laser group, and then the SF-36 mental score was worse in the surgery than in the laser group. All right, so quality of life at 6 weeks. So these are all the secondary outcomes. So the disease-specific quality of life was worse in foam group than the surgery, and then the general quality of life was lower in the surgery group compared to the laser group in these areas: bodily pain, vitality, role limitations due to emotional health, and role limitations due to physical health. The generalized quality of life score was higher in the laser compared to the foam. And then in terms of clinical outcomes, the venous clinical severity score was moderately but not significantly lower in the surgery group than the foam group at 6 weeks, but then at 6 months there was really no significant difference. Venous clinical severity score was similar between laser and surgery groups. And then the frequency of completely successfully ablating the saphenous veins was significantly higher among patients who underwent surgery and laser than those who underwent foam. And that was true at both 6 weeks and 6 months. There's really no difference between surgery and laser. In terms of complications, there was really no differences between the groups. In terms of serious adverse events, there were a few procedural complications, but it was lower in the laser group than in the foam group or the surgery group. And then at 6 weeks and 6 months, the frequency of overall complications, mostly some lumpiness and skin staining, was greatest in the foam group than in the surgery laser groups. So a few discussion points here. The quality of life measures at 6 months really didn't differ much between all three groups. And then the foam had moderately worse outcomes on disease-specific quality of life than surgery or laser, although these differences were very small, and it's uncertain whether it's clinically important. The frequency of complications was lower after laser than after foam or surgery. The baseline scores and overall improvements in quality of life are similar to those reported in prior randomized control trials, so the generalizability of the data results were pretty good. And then the three groups had similar improvements in venous clinical severity score at 6 months, but the successful ablation of great saphenous veins at 6 weeks occurred less often after foam than after surgery or laser. Some limitations, the study, so it wasn't really feasible for patients or the evaluators to be kept unaware of the assigned treatments during the study. The study didn't include groups of patients assigned to a control procedure, so placebo. So we can't really, it was hard to compare the treatments to a placebo effect. And then, since there were a lot of comparisons made, the authors argued that some of the differences may have occurred by chance. And then they said that longer follow-up will be needed to assess how durable the effects were after these treatments. Also, to note, the ablation procedures not only includes laser, but you can also do RF ablations, but RF ablation wasn't really included in this study. So the takeaway from the study is that there's really no clinically substantial differences in quality of life between surgery, foam, or laser treatment groups. However, there were moderate differences in disease-specific quality of life favoring surgery and over foam. There were moderate differences in generic quality of life favoring laser over foam. And then all treatments really had similar clinical efficacy with fewer complications after laser compared to surgery and foam. Ablation rates were higher in laser and surgery compared to foam. So that is my presentation. Are there any questions? I guess I'll open up to questioning here. Can you guys hear me? I'm going to try to unmute everyone here. Can you guys hear me?
Yeah, we can hear you, Justin.
All right, so yeah, are there any questions?
Yeah, hey guys, it's David again. Just more of a general question. Another great presentation. Thanks for that. Probably directed to Dr. V. Just given that there's no clear favorite as far as quality of life that's been shown yet, although this was an excellent study with high power. Dr. V, what's the general trend right now as far as what's being favored or what is, you know, potentially in the future questions that may need to be answered to try and establish what the most optimal treatment would be?
I'm sure maybe we're having some connection issues here. Dr. V, can you hear us?
Well, in the meantime, I don't know, Justin, if you have any, like as far as your standard, if you do a lot of sclerotherapy at your institution, or if anyone on the line, for that matter, has any thoughts. Personally, for our group, it seems like laser sclerotherapy is being preferred, but I haven't really spoken with my attendings about the you know, specific reasons and whatnot. But I kind of was interested in more of the national trend.
Yeah, so I mean, from this study at least, it looks like even though there wasn't a clear difference in terms of quality of life, it seems like that the laser really had fewer complications and better efficacy in terms of, at least at 6 weeks, in terms of treating the varicose veins. At our institution, I actually have only seen where I've only followed up one case of sclerotherapy, and I haven't personally seen the others being done. So I guess I can't really answer as to what the national trend is. But it would seem like that because of, you know, part of this, the findings of this study would favor that laser would seem to, I guess, offer better scores in terms of quality of life at certain time points after treatment, if that makes sense.
Yeah, definitely. That makes perfect sense. Thanks.
Yeah, thank you for the question.
Sure.
Can anyone else hear us right now?
I can hear you, Justin.
Yes. Yes,
Okay,
I can hear
great.
you.
Yep.
Dr. V, are you there? Huh. Well, do you guys have any other questions for me or for Amr?
Justin, if you don't mind, I think, are you able to go back to your beginning slides at the start of the presentation, not for your journal article, but the slides you were showing earlier on? The audio was a little choppy then. Just want to make sure folks got
Oh, sure.
a chance to understand the points you were making there.
In terms of invitations to do journal club presentations?
Exactly, yep.
Okay, yeah, so basically from now on we're trying to integrate the journal club presentations from all service lines. Individual service lines, I think in the past I've tried to do journal club meetings, but it's been hard to kind of invite everyone from RFS to participate. So what we're doing now is basically having a separate journal club webinar series. If you guys are interested in presenting either your service line or members, if you have any ideas for topics, feel free to go ahead and shoot either Amr or me an email saying that you're interested, and then we'll add you to our presentation schedule. And then Rajat Chan from the Communications Committee will also be periodically sending out invitation emails for anyone who wants to participate and present. So if you have an idea anytime during the year, go ahead and reply to that email and we'll get you added on as well.
That sounds great. Just wanted to thank you guys for the great talk tonight and the interesting articles, and for opening this up to the rest of RFS. I'll be sure to reach out to the clinical education team and make sure they're aware of this this exciting new thing. So really appreciate it.
Great, thank you very much.
Yeah, great
Thanks,
job, guys.
All right, yeah, thank you everyone for participating. Yeah. All right.